Yes.
Microsurgery of para-clinoid IC aneurysm with special reference to developing concept and some anatomical considerations. Now, where I have been working at Shinshu, which is the central part of Japan with a population of 2 million. And we have one university here. The first founding professor was Professor Sugita, and the second, now the fourth professor chairman, now the present. We've been operating on 600 aneurysm per year. I'd like to talk about the para-clinoid aneurysm in particular today. Now, para-clinoid IC aneurysm are those located between the cavernous sinus and a posterior communicating artery. The treatment, clipping versus coiling, as you know, the coiling is now increasing as a treatment choice for this particular type of aneurysm. In our institution, initially, most of the cases were treated by clipping, then IVR coiling surgery has been increasing in the past some 10, 20 years, 30%. As a hospital where I'm working now is also about 30%. But in the recent couple of years, no, very few, rarely clipping surgery performed. First coiling chosen in our institution nowadays. However, let me tell you some of the problem we have with the clipping surgery. Many people say visual complication is the most problem with the surgery of this particular aneurysm. If you see here, with coiling operation in our hospital in recent years, no visual complication has been experienced. However, we have some ways for direct surgery to survive. Now, what are they? One is some of the cases to overcome visual complication. The secondly, treat cases operable by IVR, such as giant dissecting blister-like aneurysm and so forth. And thirdly, to treat IVR failed cases or supplement IVR cases. Fourthly, to compete with IVR to obtain a better result. And of course, patient preference is one of the important considerations. The content of my talk today is one historical overview of the developing concept of the para-clinoid aneurysm of the ICA, and secondly, cases and recent advances. First, I'd like to talk about some points, the historical overview of this particular in reference to this particular aneurysm, the attention to IC aneurysm, and related to the arterial branching site, which was the start of my interest in this particular aneurysm. That time was about 40, 50 years ago. That was the coinciding the dawn of the skull-based surgery. I think in that case, the importance of anatomical consideration has to be stressed. And thirdly, new ideas and the concept, any type of neurosurgical procedures developed when you confront the problem in our practice. Now, problem solving is my principle in my career of being neurosurgeon. Problems such as difficult cases, technical failures, complications. Then we think about the solution by innovating new approaches, technique, and instrument, and a new management. We do apply this to clinical cases under this new concept. Then we have to reviewing the result and so forth. And if we have problem, we have to do this again. Now, some of the talks about the skull-based approaches for aneurysm. In our experience, I talk about basilar bifurcation aneurysm, then mainly on para-clinoid aneurysm. Now, in reviewing the direction of the aneurysm clip, we have found that so many wide range of clip directions we see on CT scan after surgery. By pterional approach, something like this, and by subtemporal approach, wide range of the clipping direction extended. As regard to the height of the aneurysm, neck extended from -10 to 50 millimeter in relation to the biclinodal line. Now, if you have a problem with high positioned basilar bifurcation aneurysm, the solution process would be one of the ideas would be drilling the base of the temporal bone. This is the concept of skull-based approach. Then we extend to all approaches whereby exploiting skull-based bone and minimizing brain retraction with regard to the position of the basilar top aneurysm itself. If you see upper position of the basilar top aneurysm, we do a skull-based procedures such as orthozygomatic craniotomy. If the aneurysm is located lower, we utilize a posterior clinoidectomy, anterior petrosectomy, or transcavernous approach. Laterally deviated aneurysm, we use extended pterional approach and immediately extended position the basilar bifurcation aneurysm. We often use anterior clinoidectomy or optic and roofing. And these are the number of cases we have applied to this variety of the skull-based procedures. Now, let's go on to the para-clinoid aneurysm. You see, my mentor, Dr. Rotten, used to say about the origin of aneurysm, how aneurysm developed. He is stressing all the time aneurysm developed at the arterial branching site. Of course, there are some other theories, but his main theory was the aneurysm developing at the branching site. Now, we know the naming of the ICA aneurysm. Of course, besides the intracavernous aneurysm, this is a dual aneurysm. With regard to intracranial ICA aneurysm, we have aneurysm conventionally named after the arterial branching, such as carotid ophthalmic aneurysm. I see posterior communicating artery aneurysm. I see anterior coronary artery aneurysm. One see distal bifurcation aneurysm and so forth. Now, many years ago, problems encountered with ICA unrelated with the arterial branch. In 1983, we reported an aneurysm projecting in the direction of the approaching pterional approach from the near side of the ICA wall. And then in 1989, we reported an aneurysm projecting the opposite direction of the pterional approach from the far side of the ICA wall. As the former we call the dorsal ICA aneurysm, the latter we call the carotid cave aneurysms. Now, various terminology regarding dorsal ICA aneurysm been named by various authors. Superior wall aneurysm by Yasagir, blister-like aneurysm by Suzuki, and so forth. Anterior wall aneurysm by the late Sano, so forth. Now, this is one of the cases you see on the video. If you can see a significance of recognizing dorsal aneurysm. The third, three things. One is high intraoperative rupture rate. 2 of 5 cases we initially reported ruptured intraoperatively or after surgery. Secondly, it had a technical difficulty, easy to rupture intraoperatively premature rupture. And of course, as you all know, it had a different pathophysiology, such as berry aneurysm or dissecting type aneurysm and so forth. In this particular case, after temporary trapping, we are using BEMC to cover up the rupture site around the parent artery. By the way, occurrence with this particular aneurysm in our city is 1.2%. Then remove the temporary eclipse. And the variety of angiography appearance you might see with regard to this dorsal type aneurysm. You see in case one, you see anteriorly pointing with this particular angiogram. And the case two, you see an AP view aneurysm pointing upward, and the lateral view see anteriorly projecting. And the third case, as you see, AP view, it's overlapping with the lateral projection. You see the aneurysm projected superiorly. So how do you call this? And if you further examine angiographic view, you see on a P view, usually this aneurysm pointing superior laterally and lateral view anterior superiorly. If you look at the anatomical orientation, at the coronal section, you see the aneurysm pointing superior laterally, and on the axial section, the aneurysm pointing anterior lateral. How do we call this? According to anatomy, you see Nominal Anatomica 1935 and 55, they proposed this group of naming about the location of in the intracranial location of the thing. And now, but nowadays, these group of names are used by the preference of the authors. You see, we use both this group and this group interchangeably. And then is dorsal ventral applied only to spinal cord and brainstem? If you look at the thalamic nuclei in cerebrum, you see nucleus ventralis, nucleus ventrolateralis, nucleus ventralis anterior. You see, we're using ventralis, but is it limited to the structure itself? How about the this terminology? Can this be applied to cerebral vessels? I look papers in the past, 1948, anatomist Paget proposed this name, dorsal ophthalmic aneurysm, ventral ophthalmic aneurysm, already used by anatomists. As I said before, variation, according to the variation of the ICA on the angiogram, it can be pointing anteriorly, it can be pointing superiorly. How can you call this? May better be called superior wall aneurysm. Why dorsal? We named this one at the surgical view. You see, the aneurysm seems to be settling on the dorsum of the ICA, the operation. So what do we call this? Just as a nickname. Well, surgical outcome, just in brief, is this is Japan, all Japan outcome of the this is the recent other hospital cases. They're about the same. Now, how do we currently treating those dorsal aneurysm in an institution? If we have a blister or dissect type of dorsal aneurysm, we either trapping with the bypass surgery or wrapping surgery. If the aneurysm is a circular type, we try to do our best to do clipping operation. Now, let's go on to the second aneurysm unrelated to the branching site. This is the case we confronted in 1981. In this particular aneurysm, we used a Shigeaki clip, angled defenestrated clip. Unfortunately, ended up with the occlusion of the parent artery. We went to the laboratory to solve the problem by cadaver dissection and design a safe surgical entry to this particular type of aneurysm. This is drawn by Dr. Sugita, by the way. And we designed a modified ring clip for this particular type of aneurysm. Now, does it look at the at kind of a dissection? If you look at superior view, the carotid cave is inferior medially located, as you see here, and the lateral cartoon here is anteriorly located, and aneurysm sucked in here. Now, is a carotid cave aneurysm found in all cases? That's kind of a dissection. This is the Hitotsumatsu's work at the Roton laboratory. He found 32% he couldn't find any cave, and the other were present but in different shapes. Now, anatomy of the left carotid ring region, as we increase our surgical cases, we have noticed that the aneurysm are located all around the dural penetration site, as you see here in a statistic. Immediately laterally 62%, superiorly 36%, and laterally very few, but the 22% all around the dural ring region. So we have to be prepared for that. So we call that the aneurysm according to proximal, middle, distal from the heart, and dorsal, ventral, lateral, medial, according to PNA, nomina anatomica. But then problem was we encountered by naming proximal ventral type of Y3 aneurysm, because according to specialized laboratory study, you see the internal carotid artery in this location is very complex, tortuous, difficult to say dorsal, ventrally, the lateral, medial. In the paper, looking back, our first paper published in 1986, we defined the dorsal aneurysm as aneurysm of the internal carotid artery between the posterior communicating artery branching side to the internal carotid distal bifurcation. Now, how do they have they been called historically? You see, Dr. Yasugu initially called the ventral type of ICA. Then he changed to calling inferior wall aneurysm. Other people are calling these aneurysms differently. We call this carotid cave aneurysm, for instance. And how we operate this aneurysm, the typical carotid cave aneurysm. Craniodectomy, optic sheaths are dissected, then dural ring and open, dissecting the superior hypophyseal artery region. And the carotid cave region is further dissected to expose aneurysm, not completely. And when you apply this, you have to follow the course of this tortuous artery and the dural penetration site. You have to manipulate, to negotiate. Then you finish up, finishing by complete occlusion of the aneurysm. How we have been changed of coding, names coding this type of aneurysm in this location. We have started out with carotid cave aneurysm name, then we have, we use a juxtadural ring aneurysm, then currently, if only most of the time called para-clinoid aneurysm. Discussion. You see, we said difficulty orienting due to complex tortuosity of the IC in this region, dorsal, ventral, medial, difficult to call. Then nomenclature will be easier coding by branching arteries, Dr. Roto used to say to me, or by the structure surrounding this region. Then, regardless of whether SHAs causes an aneurysm or not, SHA, we have noticed that the SHA is very important in terms of the visual complication. We nowadays routinely using visual evoked potential. Well, how people have been coding this type of aneurysm in this location? According to PubMed, we check the titles, how they use this type of aneurysm. The most often time, the para-clinoid aneurysm and SH aneurysm have been used. And according to PubMed, increasingly in recent years. carotid cave aneurysm naming was once called many times, once some pause, and then recently again we are calling come back again regarding juxtadural ring aneurysm nomenclature. It has disappeared. Very few people use it. So gripping surgeons are using this type of juxtadural SHA or something like this, and coding surgeons preferably using para-clinoid aneurysm. They don't care about the SHA or just a dural ring and any structures around it. So most often time para-clinoid aneurysm at this time is very often called, then followed by sub SHA aneurysm and then carotid cave aneurysm, both type of neurosurgeons. And this para-clinoid aneurysm, as seen on the lateral view of the angiogram, we can further subdivide into three groups. One, supraclinoidal type, clinoidal type, infraclinoidal type. Now, looking back to the dorsal aneurysm, which is not the para-clinoid aneurysm initially, but how did they call? Just tell you how do they call the blister-like aneurysm, oftentimes called, and anterior wall aneurysm, very often called also. However, it's surprising for me to see dorsal aneurysm of ICA is used so many times as well. Anyway, what I want to say is the concept of a special type of aneurysm occurred, being called by different names by different authors. But once it is concept is known to people, the cases will increase. It's a very, very interesting phenomenon I have seen. Well, the last part of my talk will be focused on the cases and the recent advances. Three topics I'd have to mention. One is the para-clinoid dorsal aneurysm by Horiuchi recently reported. It's just to say my initial paper. Now, ruptured anterior para-clinoid aneurysm, he reported, and with that proximal dorsal aneurysm, we have blister-like aneurysm and also some circular aneurysm included in his series. And this is one of the series because of the increasing size of an unruptured aneurysm. This was operated on by Triona approach, anterior clinoidectomy or dural ring dissection, then clip was placed for the anterior dorsal aneurysm or anterior para-clinoid aneurysm according to keynotes. Well, second, the topic is contralateral approach to para-clinoid aneurysm. And this is approach is very good in order to reduce the visual deficit complication. You see here, this is mostly applied for a ruptured aneurysm. And this reported by Kakizawa from my group is the indication would be we have to have a wide prechiasmatic space. Then you have to have the neck of the aneurysm is close to the midline. This is the approach, contralateral approach during the anterior clinoid process, anterior tracheum cell. Dissecting dura, covering dura, and exposing the aneurysm between the optic nerves. And in this particular case, we are applying non-ring clip. Carotid cave region. we secure ipsilateral carotid artery in the neck prior to craniotomy. Well, as I said, the visual complication is much less with contralateral approach in a series. The thirdly, significance of the superior hypophyseal artery in para-clinoid aneurysm and its surgery. Now you can see this inferior-medially SHA, and you can see if you approach contralaterally and the prechiasmatic system, you see here SAA, aneurysm, and carotid artery. Now, Gibo from our university went to Dr. Roten to study this superior hypophyseal artery in detail, numbering 1 to 7, average 3.4, distributing the recent regional optic apparatus and flow of the third ventricle. According to Critchett, he proposed a candelabra type of SAH. You see, in my experience, it can supply both sides. Now, this is the statistic we see in 14% SHA is originating from the body of aneurysm, while 86% at the neck of the aneurysm. Now, SHA, the most often we found the intracranial type of the aneurysm here. And in that case, carotid cave aneurysm may be included in SH aneurysm group, located most popular approximately. Importance of VEP, visual evoked potential, which is routinely used VEP. This is 62-year-old women, right? I see a para-clinoid aneurysm, set up an operation, the visual evoked potential is here. And then contralateral approach. This is the right para-clinoid approach, approach from the left side. The temporary clipping of the SHA, you see here flattening of the VEP, and you release it, and you come back to the former normal. And then we dissect the SHA from the aneurysm body, trying to preserve it. And again, test the occlusion of SHI. Again, the VEP flattened and then removed. So we thought it's very important to spare this SHA. Advancing the dissection of the aneurysm from the carotid cave. And applying a clip, excluding the SHI that we have tested. Postoperatively, no visual dysfunction, complete occlusion of the aneurysm. So, in summary, the developmental skull-based approach to aneurysm introduced and development of the concept of microsurgery of para-clinoid IC aneurysm reviewed with special reference to anatomy and nomenclature, and introducing a new concept increasing relevant cases measuring, and some recent development introduced. Thank you very much for your attention.
Thank you very much, Professor Kobayashi, for this comprehensive review of the para-clinoid aneurysm. We might open for one comment, if any. If not, I'd like to...
Imad, can I make a comment?
Very, very short because we are beyond
Yes,
time.
yes,
Okay.
yes, yes. So I'm indeed very happy to see Professor Kobayashi and Professor Kawase and to hear this wonderful, great lecture. I think this lecture has come out from very extensive microvascular surgical experience, which is absolutely profound. You see the number of basilar top aneurysms, the number of para-clinoid aneurysms that Professor Kobayashi has done. Now that era of fine microsurgery is gradually but surely diminishing, but his legacy and his work will always remain, at least in the history of neurosurgical books. Congratulations, Professor Kobayashi.
Thank you.
Thank you, Atul. This is wonderful. Okay, well, thanks, Professor Kobayashi. I will move to Professor Takashi Kawase, a close friend and a pioneer neurosurgeon. And